Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by our senior colleague, Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of Nath Arua and the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 395 of our pharmacotherapy series, which majors in seizure disorders. The next clinical case reads, PVS, a 22-year-old, 85-kilogram man, was recently diagnosed as having idiopathic epilepsy with generalized tonic-clonic seizures. For the past 3 months, he has been treated with 600 milligrams per day of carbamazepine, which completely eliminated his seizures. His steady-state carbamazepine serum concentration was 10 micrograms per milliliter. While at his parents' home, he had 2 tonic-clonic seizures, each lasting 3 to 4 minutes. On arrival at the hospital, that is approximately 30 minutes after the first seizure began, he was noted to be only semi-conscious. His blood pressure was 197 systolic, 104 diastolic. His pulse was 124 beats per minute, respirations were 23 breaths per minute, and his body temperature was 38 degrees Celsius rectally. Shortly after his arrival, another generalized tonic-clonic seizure began. So my question to you reads, how does PVS's current condition meet accepted diagnostic criteria for status epilepticus? What risks are associated with status epilepticus? Status epilepticus is operationally defined as either continuous seizures lasting at least 5 minutes or 2 or more discrete seizures between which there is incomplete recovery of consciousness. Because PVS has had 3 seizures within slightly more than 30 minutes and did not return to his baseline level of consciousness between seizures, his present condition meets this definition. PVS is experiencing generalized convulsive status epilepticus. This is the most common type and it is associated with the greatest risk of systemic and neurologic damage. Status epilepticus also may be characterized by non-convulsive seizures that produce a persistent state of impaired consciousness, or by partial seizures, with or without impaired consciousness. These forms of status epilepticus are associated with much lower morbidity and mortality than generalized convulsive status epilepticus. Uncontrolled, convulsive status epilepticus can cause severe metabolic and hemodynamic alterations. PVS's vital signs, that is tachycardia, elevated blood pressure, increased respiratory rate, and elevated body temperature, are typical for a patient in status epilepticus. Prolonged, severe muscle contractions and CNS dysfunction from uncontrolled seizure discharges result in hypothermia, cardiorespiratory collapse, myoglobinuria, renal failure, and neurologic damage. Even in the absence of convulsive muscle movements, Neurologic damage can occur from excessive electrical activity and the resultant alterations in brain metabolism. When seizure activity persists longer than approximately 30 minutes, failure of mechanisms that regulate cerebral blood flow is more likely. This failure accompanies dramatic increases in brain metabolism and demand for glucose and oxygen. Failure to meet the metabolic demands of brain tissue results in accumulation of lactate and cell death. Peripherally, lactate accumulates and serum glucose and electrolytes are altered. After 30 minutes of seizure activity, the body often fails to compensate for increased metabolic demands, and cardiovascular collapse can occur. For these reasons, status epilepticus is considered a medical emergency that requires immediate treatment to prevent or lessen both systemic and neurologic damage. Mortality in adults with status epilepticus is approximately 20%. Fatal outcome is often the result of the condition that precipitated status epilepticus, e.g., acute symptomatic causes, such as cardiopulmonary arrest, or stroke. Long-term neurologic consequences of severe status epilepticus may include cognitive impairment, memory loss, and worsening of seizure disorders. I would now like you to describe a general treatment plan for PVS's episode of status epilepticus. The immediate therapeutic concern in PVS is to ensure ventilation, stabilize vital signs, and terminate current seizure activity. If possible, an airway should be placed for airway protection and if ventilatory support is needed. However, this may not be possible while he is convulsing. Objects, e.g., spoons, tongue blades, should never be placed into the mouth of a patient during a seizure. If airway placement is impossible, PVS should be positioned on his side to allow drainage of saliva and mucus from the mouth and prevent aspiration. An IV line should be established using normal saline, and blood should be obtained for serum chemistries, especially glucose and electrolytes, anti-epileptic drug serum concentrations, and toxicology screens. Glucose, 25 grams, that is 50 milliliters of 50% dextrose solution, by IV push should be administered to correct any hypoglycemia, which may be responsible for status epilepticus. Glucose administration should be preceded by IV thiamine 100 mg or vitamin B complex to prevent wernicke encephalopathy. IV administration of rapid-acting anticonvulsant medication should begin as soon as possible to terminate PVS's seizure activity. Status epilepticus becomes more resistant to treatment the longer the seizure continues. Thus, treatment is more likely to stop seizures the sooner it is administered. For in-hospital treatment of status epilepticus, IV medication administration is usually preferred. The next question reads, which anticonvulsants are available for IV administration? Evaluate the available drugs and recommend a drug, dosage, and regimen for initial treatment of status epilepticus in PVS. Lorazepam, phenytoin, and fosphenytoin are the agents most commonly used as IV therapy in the initial treatment of status epilepticus. Phenytoin and fosphenytoin are indicated for treatment of status epilepticus, but owing to limitations on their rates of infusion, the onset of their peak effect may be delayed. Therefore, phenytoin or fosphenytoin is usually used after initial treatment with lorazepam. IV sodium valproate, marketed as Depakine, is available, but it is not FDA approved for the treatment of status epilepticus. Although the manufacturer recommends that Depakine be administered slowly, that is less than 20 mg per minute, it has been administered safely at high doses and faster infusion rates. There is growing experience with the use of IV valproate for status epilepticus that fails to respond to lorazepam and phenytoin, and for patients in whom phenytoin is contraindicated, e.g., phenytoin allergy. An IV form of levetiracetam is available. This drug also is FDA approved only for patients who cannot receive oral dosage forms of levetiracetam. Rapid IV administration of levetiracetam has been used. However, experience with this agent is limited. Lacosamide is also available in an IV formulation, and there are several case reports of its successful use for refractory nonconvulsive status epilepticus. IV phenobarbital is usually reserved for status epilepticus that does not respond to benzodiazepines and phenytoin. 4 IV regimens for generalized convulsive status epilepticus were directly compared in one randomized controlled trial. The study evaluated diazepam followed by phenytoin, lorazepam alone, phenobarbital alone, and phenytoin alone. For initial IV treatment of overt generalized status epilepticus, lorazepam was more effective than phenytoin alone. Lorazepam was as effective as the other two regimens, and it was easier to use. IV administration of either diazepam or lorazepam is usually effective for rapid termination of seizure activity in status epilepticus. Owing to diazepam's higher lipid solubility, it redistributes from the CNS to peripheral tissues rapidly after administration. This results in a short duration of action, that is shorter than 60 minutes. Lorazepam's lower lipid solubility prevents rapid redistribution and accounts for its longer duration of action. Lorazepam may be effective for up to 72 hours. Owing to this longer duration, lorazepam is the preferred benzodiazepine for immediate treatment of status epilepticus. Lorazepam 0.1 mg per kilogram given intravenously at 2 mg per minute would be appropriate initial therapy for PVS. Lorazepam may cause significant venous irritation, and the manufacturer recommends dilution with an equal volume of normal saline solution or water for injection before IV administration. Lorazepam may be repeated after 5 minutes if seizures continue. The efficacy of lorazepam depends on rapid achievement of high serum and CNS concentrations. Although lorazepam can be administered IM, this route should not be used for treatment of status epilepticus because it is unlikely that it would achieve serum concentrations necessary for termination of seizure activity, and there is little experience with its use for terminating status epilepticus. Midazolam given IM has been shown to quickly and effectively terminate status epilepticus when used in out-of-hospital settings. This treatment is an acceptable alternative for in-hospital use when IV access is not feasible. The most common adverse effects after IV administration of benzodiazepines are sedation, hypotension, and respiratory arrest. These side effects are usually short-lived and, when adequate facilities are available for assisted ventilation and administration of fluids, they usually can be managed without major risk to the patient. Respiratory depression occurs most commonly in patients who receive multiple IV medications for control of status epilepticus. PVS was given lorazepam 8 mg IV. Seizure activity ceased 2 minutes after the injection was completed. So my question to you reads: what drug should be administered to PVS for prolonged control of seizures? Recommend a dose, route, and method of administration. Continued effective seizure control is important for patients who experience status epilepticus. Previously, when diazepam was the benzodiazepine predominantly used for immediate control of status epilepticus, a long-acting anti-epileptic drug such as phenytoin was routinely administered at the same time to ensure continued suppression of seizure activity. Routine use of phenytoin has been somewhat de-emphasized with increased use of lorazepam. Lorazepam's apparent longer duration of effect may make routine use of IV phenytoin less necessary. Nevertheless, many centers still use phenytoin in conjunction with lorazepam. The availability of fosphenytoin for IV administration has provided an additional option for administration of phenytoin in the treatment of status epilepticus, and in most centers, fosphenytoin is preferred over phenytoin. Use of this phenytoin prodrug allows more rapid administration of large IV loading doses of phenytoin with less risk of injection site complications. Fosphenytoin is also better tolerated than phenytoin. Fosphenytoin itself is inactive. The therapeutic effect results from its conversion to phenytoin. In the US, phenytoin, administered as either sodium phenytoin injection or as sodium fosphenytoin injection, is considered the long-acting anticonvulsant of choice for most patients with generalized convulsive status epilepticus. Phenytoin causes much less sedation and respiratory depression than drugs such as phenobarbital when it is used in conjunction with IV benzodiazepines. PVS's maintenance carbamazepine therapy was previously effective. Without obvious precipitating factors such as head trauma, CNS infection, and drug or alcohol abuse, status epilepticus, in a patient with a history of epilepsy, most commonly results from poor adherence with maintenance anti-epileptic drug medication. Therefore, IV fosphenytoin is a good choice for re-establishing effective anti-epileptic drug therapy for PVS. Phenytoin is an acceptable alternative if fosphenytoin is unavailable. Regarding loading dose, whether or not PVS has a detectable serum concentration of carbamazepine, he should be given an IV loading dose of either fosphenytoin, 20 mg per kilogram phenytoin sodium equivalent IV at 150 mg per minute, or phenytoin, 20 mg per kilogram IV at 50 mg per minute. After administration of either of these loading doses, serum phenytoin concentrations should remain greater than 10 micrograms per milliliter for approximately 24 hours. This will allow time for determination of PVS's serum carbamazepine concentration and estimation of an appropriate maintenance dose of oral carbamazepine once oral therapy can be restarted. In this setting, the use of IV phenytoin or fosphenytoin is a temporary measure. PVS's previous positive response to carbamazepine indicates that he should likely continue to receive this drug as his oral maintenance medication. IV phenytoin can be administered by direct injection into a running IV line. The rate of administration should be no faster than 50 mg per minute to minimize the risk of hypotension and acute cardiac arrhythmias. Cardiovascular status, that is blood pressure, and electrocardiogram, should be monitored closely during administration. Hypotension or electrocardiographic abnormalities usually reverse if the administration of phenytoin is slowed or stopped temporarily. Fosphenytoin can be given by either direct IV injection or, after dilution in any suitable IV solution, by infusion at up to 150 mg phenytoin sodium equivalent per minute. Absence of propylene glycol as a diluent renders fosphenytoin potentially less likely than phenytoin to cause cardiovascular adverse effects, but this advantage is not well supported. Electrocardiographic and blood pressure monitoring is recommended when this drug is given IV. Pruritus and paresthesias, usually localized to the face and groin, are relatively common side effects during IV fosphenytoin administration. These sensations are not allergic reactions to the medication. Their occurrence is related to the administration rate, and they are reversible with temporary discontinuation or slowing of the injection. We will now briefly look at maintenance therapy. The undetectable serum carbamazepine concentration appears to confirm the role of non-adherence in this episode of status epilepticus. Because PVS was previously well controlled on 600 mg per day, this would be a reasonable target dose. Because PVS may not tolerate carbamazepine if restarted at the prior maintenance dose, gradually escalating up to this dose should be initiated as soon as PVS can take oral medication. PVS should be counseled regarding the importance of taking his medication according to directions, and any potential barriers to adherence should be addressed. We will now briefly look at alternative therapies for refractory status epilepticus. Phenobarbital may be useful for treatment of status epilepticus if the patient cannot tolerate phenytoin or when seizures continue after administration of appropriate loading doses of phenytoin. Patients who receive phenobarbital after being treated with IV benzodiazepines should be monitored closely for respiratory depression because this effect may be additive. Equipment and personnel to provide ventilatory assistance should be available. Status epilepticus that does not respond to lorazepam and a longer-acting agent, e.g., phenytoin or fosphenytoin, valproate, levetiracetam, phenobarbital, or lacosamide, is considered refractory status epilepticus. From 20% to 40% of patients with status epilepticus will progress to refractory status epilepticus. In such circumstances, an alternative longer-acting agent from those mentioned above may be considered, and, in recent years, the use of such third-line agents was a common practice. Recently, it has become a more common practice to escalate therapy to the use of an anesthetic agent after failure of second-line therapy. The most commonly used anesthetic agents for refractory status epilepticus are midazolam and propofol. Pentobarbital is also sometimes used. Significant respiratory depression is expected with these therapies. Patients require intubation and mechanical ventilation. In addition, vasopressors, such as dopamine or dobutamine, may be required to control hypotension. Constant EEG monitoring also is required to assess the anticonvulsant effect of the drug and to gauge the level of anesthesia. Midazolam is given as a loading dose of 0.2 mg per kilogram IV and is followed by an IV infusion of 0.2 to 0.6 mg per kilogram per hour. Many practitioners adjust the infusion rate to either control electrographic seizures and/or to produce a burst suppression EEG pattern. Most protocols for anesthetic therapy of refractory status epilepticus recommend attempts at gradually reducing the dose of medication after 12 to 24 hours of treatment. If clinical or EEG seizure activity recurs, the dose is increased again to produce the desired EEG pattern. Anesthetic agents may need to be continued for several days or even weeks in some patients. Continuous IV infusions of propofol or midazolam are also useful for refractory status epilepticus. These therapies appear to be less likely than pentobarbital to cause severe hypotension that is refractory to vasopressors. Because no direct comparative trials of pentobarbital, propofol, and midazolam have been performed, physician familiarity and preference often guide the choice between these agents for the treatment of refractory status epilepticus. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. On behalf of our senior colleague, Dr. Nath Arua, I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 396.